All right. And Mr. Chair, would you like me to call roll?
Certainly.
All right. Delegate Bourne, Delegate Goditis. I see you, Delegate. Delegate Ware, Senator Sasslaw.
Here.
Senator Serville.
Here.
Senator Spruill.
Yeah.
Secretary Carey. Believe I saw him on the call just a moment ago. Commissioner Wright, represented today by Julie Blauvelt.
Yes, here.
Vice Chair Heretic, Chairman Barker.
I'm here, so thank you.
Mr. Chair, you have a quorum.
Thank you very much. What we'll be doing today is getting a number of people presenting to us on things that have been ongoing, and so also sort of laying out what our responsibilities are and the steps that we'll be taking later on. We will not be taking a lot of action today, but we will be hearing things, and then we can take up a consideration of some options with some of the pieces of legislation that have been referred to us at our next meeting. And we do have a large number of people signed up for public comment. We will do that at the end. That will then respond to some of the issues that are raised as it relates to some of the bills that have been referred to us. And we will then take those up for consideration at our next meeting. And with that, I will call on Tom Stevens to talk about the commission and what sort of the background is and the purpose of the commission.
Thank you, Senator. Can you all see my screen?
Yes.
I see it. Yep.
Great. Just quickly going over the powers and duties of the commission. This is section 30-342. Commission is to monitor the work of appropriate federal and state agencies in implementing the ACA. It's to receive information provided to the commission pursuant to 343, which is assessment of mandated benefits bills, and on the basis assess the implications of the bill's implementation of the Commonwealth and businesses, etc. Consider the development of a comprehensive strategy for implementing health reform in Virginia. It's to receive periodic reports from the Bureau and recommend health benefits required to be included within the scope of the EHBs. The fifth power and duty is the bulk of the commission's work, at least in recent years, is to assess proposed mandated benefits and providers as provided in section 30-343. It's also to conduct other studies as bills get referred and to develop any legislative recommendations. Section 30-343 outlines the process for the commission to assess bills. Standing committees request a commission assessment. Past year, Senator Sasslaw had a bill which gave us a definition of a mandated health insurance benefit or provider. That's coverage required under the laws of the Commonwealth to be provided in a policy of accident and sickness insurance that includes coverage for specific healthcare services or benefits, places limitations or restrictions on deductibles, co-insurance, co-payments, or any annual or lifetime maximum benefit amounts. Or 3, includes a specific category of licensed healthcare practitioners from whom an insured is entitled to receive care. There previously was not a definition of mandated health insurance benefit or provider in the commission's enabling legislation. So this gives us a definition to understand which bills need to go to HERC.
I think 1473 was actually Barker's bill, but put in under my name. Is that correct, George?
That's because we were limited in number of bills that I could put in. But yes, you are correct. So we got that in there to get the clarification on what the definition is, so that we won't have any questions raised in the future or disputes as to what's covered or not covered.
So for a mandated benefits bill, the chair of the House Labor and Commerce or the Senate Commerce and Labor Committee requests the commission to assess the proposed health insurance mandate. Commission has 24 months to complete the assessment. After receiving a request from the chair, the commission may request the Bureau to conduct a step 1 assessment. This assessment will address whether the exchange would likely determine that the proposed mandate exceeds the scope of the essential health benefits and the extent to which the coverage in the proposed mandate is already available under qualified health plans already offered. The Bureau provides the commission with a memorandum presenting the results of the step 1 assessment and present the results at a scheduled meeting. You all will hear those today. Using the step 1 assessment, the commission determines whether further assessment of the proposed mandate is warranted under section 3343C of the code. The commission determines further assessment is warranted. It will request JLARC and the Bureau to conduct a step 2 assessment. A step 2 assessment, JLARC and the Bureau provide the commission with 2 separate but coordinated reports. JLARC looks at background on proposed coverage and medical condition, the medical efficacy and effectiveness of proposed coverage, the current availability and utilization of treatment, current financial impact on individuals without coverage, and its consistency with the purpose of health insurance and impact on public health. The Bureau's assessment looks at the expected impact on utilization of services and providers, expected impact on premium cost, expected additional cost to the state as required by the ACA, and expected impact on the total cost of healthcare in the Commonwealth generally. So the ACA requires that a state cover certain costs when they mandate benefits. The ACA says that a state may require that a QHP offer benefits in addition to the essential health benefits, but for any additional mandated benefit, state shall make payments either to the individual enrolled in the QHP offered in the state or on behalf of individuals directly to the qualified health plan. Subdivision A1, section 38.2.6506, that's in the health benefit exchange bill that you all passed a couple years ago, provides that a plan cannot be certified as a qualified health plan if it offers any state mandated health benefit in addition to the EHB. So going forward, mandates cannot be off. Mandates that are required by the state after 2011 cannot be offered by a qualified health plan on Virginia's exchange. I think the Bureau has raised concerns about this section. It may not, it may be in conflict with provisions of the ACA, but they can touch on that later.
Okay.
Also in the code, application of mandates to the state employee health insurance plan. Any mandate that the state requires on private insurance, the code also requires that the state health insurance plan provide that same coverage. Just some of the bills that are in the process right now, SB 423, this was coverage for hearing aids. You all will hear about that momentarily. Step 1 assessments, all mandates referred in 2020 except those undergoing step 2 assessments. The Bureau will report on later this meeting. Last December, you all asked for, requested 2 step 2 assessments, one for coverage for prosthetic devices, which was one bill in 2019 and a couple others in 2020, as well as step 2 assessment on coverage for donated breast milk. You received a few bills on that as well. JLARC and the Bureau have indicated that they anticipate completing those assessments in the late fall.
All right.
And that's all I have for right now.
All right. Any questions anyone has? All right. If there aren't any, then we'll move to the summary of the report on SB 423 from the 2020 session. and the requirement that was built into the budget, item 487C 1 through 3. And who will be presenting on that?
I think that's JLARC first, Mr. Chairman, and then the Bureau.
Okay. All right.
Good morning, everybody. Thanks for having us. I'm excited to share our findings with you this morning. I am going to work on sharing my screen. You all let me know if that does not work. Can everyone see that?
Just fine.
I think so.
Wonderful. Okay. My name is Tracy Smith, and I'm one of JLARC's associate directors. I supervise the research that our staff conducted last year for the Step 2 review of SB 423, which of course relates to hearing aids for children. And I believe you have a copy of the written report, which has some more details in it that I won't cover necessarily today. I think we sent that to Tom in December or so of last year. So Tom went over this, but basically JLARC is asked to evaluate, what I've done is put the questions that we are asked to look at into these 3 buckets for you all, and the presentation will answer those. So first, is there evidence that the proposed treatment is effective? Next, how commonly used and available is the proposed treatment? And finally, what's the cost of the treatment for individuals absent health insurance coverage? Senate Bill 423 requires coverage of hearing aids and related services for children who are under the age of 19. And essentially, the insurance plan would pay up to $1,500 per year, up to $3,000 in total on a 2-year basis. And so that's the coverage limit. And the other provision of the bill is that hearing aids have to be recommended essentially by the child's ENT. Let's go back here. Okay. We wanted to give the commission a sense for how prevalent hearing loss is among children. And so our staff estimated that fewer than 1% of children have hearing loss. And this is a Virginia-specific number. This equates to between 500 and 2,000 children in the plans that the mandate would apply to, which would be individual health insurance plans and fully insured group insurance plans. And we arrived at this estimate using U.S. Census data for Virginia. We also looked at data collected from hearing screenings that are conducted of newborns in Virginia. And we also estimated the prevalence of hearing loss in Virginia children who are enrolled in Medicaid, as well as those who are enrolled in the state employee health plan. And so, really, when we look at those percentages for each one of those groups, the highest level of presence of hearing loss was about 0.5%. And so because it is a somewhat rough estimate, we've given you kind of the less than 1% ballpark here on the slide. The other thing we wanted to clarify for you all is that, and I'm sure this sort of goes without saying, but of course, hearing loss ranges quite a lot among individuals. And so doctors rate hearing loss on a scale from mild to profound. And so in our report, there are a couple different levels that we describe in the report, but essentially the lowest level is mild, all the way on up to profound. And hearing aids are necessary and effective in almost all cases, except for the most profound cases. When a child or even an adult has profound hearing loss, even amplified devices and sounds make sounds difficult to hear and understand. And so in those cases, the alternative to hearing aids would be a cochlear implant. That is not, as I'll talk about in a minute, appropriate for the mild or severe hearing loss, but it is for the profound hearing loss. And that particular treatment does tend to be covered already by health insurance plans. So one of JLARC's responsibilities for these health insurance mandates is to determine whether there are alternative treatments to what would be mandated by the legislation. And so for hearing loss, there really is consensus that there are no alternative treatments to hearing aids for children who are experiencing from mild to severe hearing loss. And as I said, for children with the most profound levels of hearing loss, hearing aids may not be effective or appropriate. And so cochlear implants are really the alternative there. Health insurance plans do tend to cover cochlear implants, but again, this is not an alternative for children who are experiencing the lower levels of hearing loss. And so that's important when we consider our charge in this research, which is to determine to what extent are there alternative treatments that might already be covered by health insurance plans. The other important thing to understand, and again, I think this probably goes without saying, but there is consensus among experts that hearing aids really are effective at helping children develop speech and language skills. And research has shown that children who receive hearing aids early on in their hearing loss do develop stronger speech and language skills. And so being unable to afford or access hearing aids for very young children, and we're talking about newborns on up to 2 years, really will negatively impact their development. And so on to the next question that we're asked to answer for you all, and that is, in the absence of health insurance, what is the cost of the treatment to an individual or a family? Hearing aids and the services that children need to receive along with them cost between $2,200 and $3,600 per ear during the first 2 years. As a reminder, SB 423 caps the coverage amount at $1,500 per year. And so even with this coverage, families would experience out-of-pocket costs to cover hearing aids and related services. And the majority of children do require hearing aids in both ears because they experience hearing loss in both ears, and that essentially does double the cost to families. And so on this slide, what I've tried to do is break down for you the impact of coverage on a family's out-of-pocket cost. And so in year one, the cost of hearing aids and those services that go along with them would cost a family between $1,900 and $3,300. With insurance then covering the $1,500, that brings the family's out-of-pocket costs down to between $400 and $1,800. Then in year two, it's because the cost of hearing aids, I'm not sure why that was jumping around so much. The cost of hearing aids has already been covered, and it's unlikely that hearing aids would have to be replaced that early. In year two, really children are only needing those services that go along with hearing aids, which might be being fitted for an ear mold to ensure that the hearing aid continues to fit them correctly, particularly given these young children's rapid rate of growth. And we estimate that would cost about $300 for those services. However, because the cap would have already been met, that $1,500 cap, families would still have to cover that $300 cost of services, which again is an estimate in year two. And so then after 2 years, basically what you have is that the total cost to the family is about a third to a half of what it would be without insurance coverage. And so then again, in year three, you've got the services again, year four services again, because hearing aids do tend to last somewhere between 3 and 5 years. And so then in total, after 4 years, a family's out-of-pocket costs essentially have gone down from $2,800 to $4,200 down to $700, a range of $700 to $2,100. And so, Mr. Chairman, the main takeaway from our research, and I know I've gone through this pretty quickly, is that hearing aids are an effective and a necessary treatment for children. There really are no effective alternative treatments or therapies. Insurance coverage of hearing aids is uncommon. That's one thing that I didn't cover in the slides, and we found that is not common for health insurance plans, but some do cover them. And families do incur out-of-pocket costs that amount to several $1,000s without coverage. So my last slide here is really just intended to bring to shine a little bit of light on some other issues that Tom really kind of introduced for you, and that I think the Bureau will cover in more detail. Essentially, under the Health Benefit Exchange, new health insurance mandates don't apply to plans that are part of the exchange, as Tom said. And so what we concluded, and this is described in much more detail in our report, the coverage from SB 423 essentially would be fairly limited. Essentially what you have left it would cover those plans that are not part of the exchange, which would be a limited number. And Julie, Brad, please correct me if I'm wrong on that. In terms of the fiscal impact, that's important for the group to understand as well, because there was budget language indicating that if there is a fiscal impact to the state of this particular coverage, the coverage would not go into effect on July 1. So the health mandate would apply to the state employee health insurance plans. Because the state subsidizes the premiums for those plans, the increased costs would result in a fiscal impact to the state. And so that does have implications for, kind of this legislation moving forward, given that budget language. And I just wanted to make sure that you all were aware of that. The other issue that has come up is CMS guidance, and Tom mentioned that too. I know less about that, and so I'm hoping that the Bureau will go over that a little bit more. And I do think that guidance may have evolved some since we did our report in late fall. And so this might be a good time to go ahead and turn it over to the Bureau, because I'm quickly getting out of my depth here. But we wanted to make sure that the Commission understands that with the Virginia Health Benefit Exchange Law and the new CMS guidance, there are some issues that I think policy issues that really would need to be tackled and considered going forward with respect to health insurance mandates. So, Mr. Chairman, that wraps up my presentation, and I'd be happy to try to answer any questions for you all.
All right. Thank you for doing that. Anybody have questions at this point?
Mr. Chairman, I have a question.
Certainly, Senator Thurble.
Thank you, Mr. Chairman. Thanks for the presentation. One question I had was, you all look at all as to what the cost to taxpayers is for children who do not receive the hearing aids? I would assume that if kids don't get those types of services, that they require a lot of remedial educational expense that they otherwise might not need because of their, the inhibitions on their ability to learn.
That is an excellent question. That's not actually within the scope of what we looked at, but I think that is certainly there's connecting the dots there is appropriate. And I think because hearing loss for so many of these children occurs, when they are born or soon around that time, there is a potentially a profound impact on their speech and language development. And so I do think that what that would result in is the need for not only services to help with improving their hearing and their speech and language, but also their education in general. And so tying your question back to the research showing that the earlier a child receives this kind of treatment, the better and more successful they will be in terms of that speech and language development. If you tie that to dollars, then yes, presumably fewer public dollars would need to be spent on those types of services to get children ready and to be successful in school.
From the script survey, I can answer that for you. I'm sorry, Mr. Chairman. I can answer that for you. I wear hearing aids, and I have a speech impediment now because at an earlier age, when I was small, of course, we could not afford to go to the doctor to have those. So when all my brothers and sisters talk very well now, and I have a speech impediment, sometimes you can't. But now I do have a hearing aid in now. When I was grown in the late 60s, I first started wearing them because I keep looking at somebody's mouth all the time. So when some people think I talk funny now, but they were saying, had I heard these hearing aids going to the doctor at an earlier age, that my speech impediment would have improved much more than what I am now. So at an earlier age, had I was able to have hearing aids, that my speech impediment would have been much better than what it is now. So I came into the game late, but it was late. So when you can understand me a little bit now, but in the early years, without these hearing aids, you had to ask me a question 10 times. So that's what it was. They said to my mother, remember, Scott, I had 16 brothers and sisters, so we couldn't afford to. So at that early age, I did not have that, so we had a hard time to getting help to get me to first hear what you got to say, and then my doctor says that your nose and your ears have an effect on your speech, and that was what happened to me. So after all these operations I had, and I do wear hearing aids now, so I can understand. You can understand me a little bit now.
All right. Thank you very much for that comment, Senator Spruill. I guarantee you make sure that we know what your opinions are now. So there's no ambiguity with Senator Spruill on anything. So, but a quick question. How did you look at sort of the impact as to how many of the children who would be affected by this legislation or that would potentially be affected by legislation would not be affected, would not benefit from it because they're in ERISA plans or with the provision that Tom talked about earlier relating to the health insurance exchange?
Good question, Mr. Chairman. So we did not look at how that number would be affected with the health benefit exchange. My understanding is that when our staff did that estimate of the number of children who potentially would be covered under the health mandate, that would include the plans that the health mandate would typically cover. So setting aside the health benefit exchange law, and that was between 500 and 2,000 children.
All right, thank you. Any other questions anyone has?
Mr. Chair.
All right. Yes, Delegate Goodaitis.
I know I'm supposed to know this, but I'm assuming this is not covered under Medicaid.
That would be a question for maybe BOI. I don't recall.
So when you calculate the number of children, 500 to 2,000 possibly in the Commonwealth, some number of those might be in Medicaid covered families, no?
No, I don't believe so, the way the analysis was done. But again, I sort of supervised and did not analyze. And so what I can do is get back with you, Mr. Chairman, if it's okay with you, I can get a more specific and accurate answer to that and send it along to the members.
That sounds good. We appreciate that. So please do. All right. Any other questions at this point? All right. On to Julie with the Bureau of Insurance.
Mr. Chairman, members of the commission, my name is Brad Marsh. I'm the health insurance policy advisor with the Bureau of Insurance, and I'm here today to present BOI's portion of the analysis.
All right, good. Glad to hear.
As Jay Lark stated, Senate Bill 423 and from the 2020 General Assembly session provides for coverage of hearing aids and related services for children 18 years or younger when recommended by an ENT without copayment or fee. It also includes related services such as ear molds, initial batteries, and other necessary equipment, maintenance, and adaptation training. Subsequently, language in the Appropriation Act required the Health Insurance Reform Commission to assess the fiscal impact of the coverage requirement to include a determination by the Bureau of Insurance and JLARC. Upon finding no fiscal impact, coverage could commence on July 1, 2021. Prior BOI analysis indicated that coverage for hearing aids is not included in the Virginia Essential Health Benefit Benchmark Plan and therefore would be considered a new mandated benefit. However, as Tom discussed earlier, Section 382-6506A1 of the Code of Virginia does not allow any new mandates to be offered by exchange plans. Even though there would be no defrayal cost to the state because of the prohibition on applying these to the plans, there would be a fiscal impact to the state. The bill would still apply to the state employee health plans, which result in a small cost to the state. That is essentially the end of the analysis we have on the fiscal impact here.
Does anybody have any questions for Mr. Marsh? All right. Given that I gather we're supposed to make a determination as to whether or not there is an impact to the state, or cost to the state as a result of the language that's in the budget. Is that correct, Mr. Stevens?
Yes, sir.
All right. Does anyone want to make a motion related to whether there is a cost to the state if this were to go into effect?
Mr. Chairman.
Yes. Senator Searle.
Thank you. I mean, from my perspective, this is a very small investment to make in terms of the benefits that it reaps for taxpayers down the road. And, it's one of my issues with the way we often evaluate cost is that we often look at the cost, immediately, like right in front of us in that fiscal year, instead of the downstream benefits that often occur with these types of investments. And I'm not really clear what standard we use, but it's very clear to me that if we make this, small 1,000, whatever it is, $2,000, $3,000 per child investment, it reaps, tens of thousands of dollars of benefits for taxpayers over the child's life. And so it would strike me that there's no cost on a long-term basis. There might be a short upfront small investment, but I would think you might even would see that less money coming out of the education side of the budget as soon as we make that investment. So I guess, I don't know what the motion is. I'm new to this commission, but my motion would be that we, certify that there is no cost. If that's a motion, you might be able to frame it or articulate it better than me, but that's my view of it.
I would second that, George.
Okay. All right.
Senator Barker.
Yes.
Senator Servell is right. You've got to also look at the alternative cost. I mean, that just simply can't be ruled out. And I would imagine the alternative cost, downstream is going to be 10 to 20 and maybe larger times the cost of, supplying that hearing aid during the formative years.
All right. All right. Any further discussion on this?
Yes, Mr. Chairman.
Yes.
So what was the motion that is not a cause?
Yeah, the motion that Senator Searle made was that we determined that there's not a cost as a result of the offsets to the expenditures that would be made by the state in terms of savings in the future.
Okay.
We don't have, as best I'm aware, we don't have any information on that and what the magnitude of that would be and whether it would fully offset that. But I think that's what what the motion from Senator Searle is.
Thank you.
Okay. Is there anyone from either JLAC or the State Corporation Commission of Bureau of Insurance that could comment and provide any information on potential savings that would offset the expenditure that would be made?
Chair.
Yes.
Just want to make sure, I'm going to read from the budget language. The Commission, the Bureau, and the Joint and JLARC, if their findings determine that no fiscal impact shall be incurred by the Commonwealth, the coverage may commence. I would point out that both JLARC and the Bureau found that there is a fiscal impact on the state.
Okay.
Mr. Chairman, that's what's bothering me.
Right.
So I'm saying that if there's no, based on a motion, then you're saying that these coverage would not be, for children would not be covered. Am I understanding that way?
Now, the motion would be to say that there is not a cost, despite the fact that the Bureau of Insurance and the JLARC could determine that there is a cost because of future savings that would offset the expenditures that would be made. And
so, Mr. Chairman, are you saying, I'm still confused, are you saying, are we putting money in the budget for this? Are we gonna cover this at all? That's my question. This being covered by us at all?
What's proposed in the motion from Senator Surville is to say that the law could go into effect, and that when it would go into effect, then there would be payments that would be made to provide the coverage of up to $1,500 per year, for 2-year period. So.
Thank you so much.
Mr. Chairman, Delegate Ware's hand is up.
Excuse me? Oh, Delegate Ware's hand is up? Oh, I didn't see that. Okay.
Thank you, Mr. Chairman. Thank you, Senator Surville. And I apologize. For some reason, my camera is not working this morning, but I hope you can hear me.
We can hear you.
And I'm speaking out of past practice. And what we have often done in the past is to offer a recommendation on behalf of, or not on behalf of, these proposals that come. And I guess I'm a little confused. It seems to me that what we're doing here is simply, or as the motion currently goes, we are simply making a statement that we believe on balance that financially it's a wash or a plus. And I wonder, and maybe I'm out of turn, maybe we've moved past this past practice, but it seems to me that it would, to some extent, overcome objections if we simply, made a motion on behalf of the commission that we favor this, or that we recommend that the General Assembly adopt this. And Tom may be able to correct me procedurally that maybe we've transcended that by our current practice. So I put that out there, Mr. Chairman, and I hope my question is clear.
I think it's clear. The issue we have here is that this bill went through a little bit of different process than some of the others. Basically, the bill passed, but then there was this clause put in the budget that required a determination to be made through this process as to whether or not there is a fiscal impact to the state. And clearly there is a expenditure that the state would be incurring. And we do recognize that there that there are savings benefits to this that could produce some savings. We don't have quantification of that at this point to determine whether or not that equals or exceeds the cost that would be incurred. But what we're called upon to do is to make a determination as to whether or not there is a fiscal impact to the state. And if so, then the bill would not go into effect tomorrow. So that's sort of where we are at this particular point. And the motion from Senator Surville would say that we determined that there is not a fiscal impact to the state.
Thank you for that clarification, Mr. Chairman.
All right.
Mr. Chairman,
if you wish, Delegate Ware, you could make a motion relating to things, and it probably would require, actually, the determination may require action by in the budget to appropriate monies for it as well. So I don't know the full answer on that at this point.
Initially, it would.
Yeah. All right. Is there any other questions or discussion?
Mr. Chairman?
Yes.
I think that Mr. Stevens' screen may have froze. I expect that he'll reconnect momentarily, but in the meantime, perhaps Ms. Blauvelt, looks like she has her hand up and might want to speak, Mr. Chair.
That's not good. All right. Ms. Blauvelt.
Yes, thank you. I just wanted to add that, when we're reviewing the forms that are going to be effective, the Bureau of Insurance, we receive the forms from the carriers, and it may not be clean, that these forms will, have this benefit in there for July 1, because the forms have been approved, about a year ago for a lot of these plans. So there will be a little bit of catch up, I think, as far as the forms go, just to make the committee aware of that.
Okay, thank you. All right, Tom, are you back? Wendy, Delegate.
Hi, I just wanted to say, I was just looking at an article and it talked about how many, maybe too many students with disabilities in Virginia are routed to private schools. The tuition for those schools ranges from $22,000 to $97,000 a year. And Virginia at the moment has committed, as of a couple of years ago, $186 million a year to this program. So, I mean, it's extremely expensive. Just wanted to throw that in there.
All right.
Mr. Chairman.
Yes.
I don't know if this is appropriate or not, but I just wanted to clarify back to my earlier response to Senator Sorrell's question. I think certainly children receiving hearing aids at the youngest possible age would have a benefit in terms of reducing the amount of publicly funded services that they receive. But I think there's an important assumption that is made there, which may be accurate, but maybe not, which is that families would not invest or be able to invest in the full cost of the hearing aid and the services without health insurance. So I think there is an assumption potentially being made that without health insurance coverage, all of those families are going to go without hearing aids for their children. And we at JLARC don't have data on how often that would occur. I think it is certainly likely that would occur in some cases. But, I think the extent to which there is positive kind of downstream effects depends on the extent to which families are willing and able to pay for those out-of-pocket costs absent insurance. And so I don't know that those downstream effects, we don't have data to suggest that the downstream effects and positive benefits would actually offset the cost of the mandate to the state. So I just wanted to clarify that for the commission.
All right. In your work that you did on this issue, was there any information from the school systems as to what percentage of children had hearing losses and what percentage of those then had hearing aids or a cochlear implant?
No, we didn't look at that data. Last year, as you may know, we did do two very extensive studies of special education services and private day school services in Virginia. And so, it's possible that the teams that did that work at JLARC would have data from the Department of Education on that. I don't know for sure. But I think, at least within the scope of the work that we did for this particular issue, we don't have that information from schools.
All right. Okay. Thank you. All right. Is there any other discussion or questions on this issue?
Mr. Chairman?
Yes.
I'm sorry, I'm having technical difficulties, so I may have missed if you all discussed this. But the budget language, it says if the findings determine that no impact shall be incurred by the Commonwealth, such coverage may commence July 1, 2021. When it says the findings, it refers to the findings by HERC, the Bureau, and JLARC. Since 2 out of the 3 have found that there is a fiscal impact, it's not clear to me from the language,
right,
while determining that there isn't, will override their findings.
Okay. Where would we get clarification of that?
I think a court.
Right. Okay. All right. Senator Zaslow, you're muted.
You're muted.
I think what he's saying is we can't use the potential offset, and say that overall there's no cost, because the fact that there's no cost would occur at a later date of the savings that we're talking about. And that's probably, I'm guessing that's what Tom is saying. Am I correct, Tom?
Yes, sir. I don't think it was anticipated in that budget language that you all would look at future offsets.
Okay.
I think the other point that he was making was that it's unsure, it's uncertain, it's not clear if the Bureau of Insurance and JLARC have determined that there is a fiscal impact and HERT determines there's not, then which of those opinions would override, would determine make the determination as to whether or not the bill goes into effect.
Mr. Chairman.
Yes, Senator Servo.
Thank you. I think what Mr. Stevens is saying is that my small skirmish in my war against how the state does its fiscal impact statements would create some potentially unnecessary and concerning legal chaos about the certainty of the state of the law, and that perhaps we might be better not following my motion, although he didn't want to quite say that probably. But I think that's what Tom seems to be saying.
Yeah,
so
there would have to be a determination somewhere along the line to sort out who
just like a lawyer.
Mr. Chairman, we need to move this along. And I think what he's saying is I should withdraw my motion. I think I will do that.
I'll withdraw the second.
Okay.
Yeah. So I guess I'll make a motion that we find there's a very teeny tiny small cost.
All right. Is there a second to that motion? A teeny tiny second. So
second. I second that.
All right, Senator Sproul. All right. Having discussed this for a good while, is there any further question or discussion? All right, Tom, you want to call the roll? The motion is that there's a teeny tiny. Sean, I guess, do that. So, yeah, go ahead.
Delegate Goditis.
Wait a minute, I'm unclear. Clarify for me.
Yeah, the motion is that we determine that there is a teeny tiny fiscal impact to the state.
Yes.
Delegate Goditis, aye. Delegate Ware.
Aye.
Senator Stasslaw. I think I saw an aye from Senator Stasslaw. Senator Serval.
Aye.
Pardon me. Senator Sproul.
Aye.
And Mr. Chair.
Aye.
Delegate Bourne votes aye. Sorry.
Pardon me, Delegate Bourne. I didn't see that you had arrived. That'll be 7 ayes, 0 nays.
All right. Thank you. That motion carries. So. All right. Moving along, we will now go to the overview of legislation referred during our recent 2021 session and special session 1. So since there were 2 sessions following on each other, they're back in February. So
thank you, Mr. Chair. You all were referred a few bills this year, starting with HB 1822. This was referred to you all from the Senate Commerce and Labor Committee. Delegate Askew. This would prohibit health insurance companies from setting amount exceeding $50 per 30-day supply of a tier 1 or tier 2 prescription asthma inhaler. So a cost sharing cap. This is in Senator Staslaw's bill. It makes clear that these kinds of bills that put limits on cost sharing requirements do go to HERC. So that's why this was sent here this year. It's similar to the bill you all passed a few years ago about insulin. HB 1922 requires that the state plan for medical assistance provides coverage for necessary reproductive health care services, as well as coverage under the FAMOUS plan, and requires private insurance to cover the specified services as well. So those 2 are mandated benefit bills. There was also a study sent by the House Committee on Rules from Delegate Helmer, directing HERC to study mandating insurance coverage for infertility treatment for those who are receiving cancer treatment. Delegate Helmer put in a bill in 2020, HB 776, which had already been referred to HERC, and the Bureau has performed a step 1 assessment on, which you will hear later. You all were also referred a number of bills that are not mandated benefits bills. HB 2021 from Delegate Geditis and HB.
I think Mr. Stevens may have frozen again, and
Okay.
I assume we'll be back shortly. Pardon me, Mr. Chair.
All right.
Mr. Chair, I can continue with the rest of the bills referred during the 2020 session.
Okay, that would be great. Thank you.
We have HB 2021, Delegate Goditis' bill about health insurance provider contracts. We have HB 2274, Delegate Weber's bill, also about provider contracts. And SB 1323, which is worker classification for independent contractors. And I think once Tom is back on here, he'll be able to explain these further. Thank you.
Mr. Chairman?
Yes.
I don't have the number offhand, but I had a version of the health insurance contract bill, which I think you remember because you carried a version of it in the 2020 session.
Right.
And my bill got heavily amended to where a small part of it passed, but the rest of it, I think it was intended that it be referred to HERC because it's sort of the flip side of what Delegate Geditis' bill was. So I think my version of that should also be on the list. And if I need to make a motion, I can make a motion. We also consider that as part of her bill and Delegate Weber's bill also, I think.
All right.
What small part of my bill was acceptable that we passed, and then the rest of it need to be looked at.
Right. And what's your bill number?
I will get it up right now.
SB 1289.
Okay.
Sounds right. Yeah, that's it.
Yeah, so Senator Serval had SB 1289, as he mentioned. A small part of it did pass, dealing with discrimination against litigants. HERC was also referred a bill that was similar in 2020 by Delegate Robinson, so I believe that should be as part of y'all's discussion as well.
All right.
And then finally, this SB 1323 from Senator Dunavant. This was referred to you all from the Senate Committee on the Judiciary.
Committee, yeah.
This deals with worker misclassification and which test is used to determine if a worker is an employee or an independent contractor.
All right.
And those were the bills you all received.
Okay. All right. What I would suggest that we do is that we get information on all those and have staff send us all those information on those bills that were identified during the 2021 sessions and have us take those up at our next meeting. There may or may not be people who testify today on that, so that might provide some additional information and perspective on that. And that we try to have the patrons of the bills be available when we have our next meeting then. So,
Mr. Chairman?
Yes.
Do we need to make a motion on the Scout Surveyor's bill to add it in? Or we just put it in?
Was that referred here, or do we need to just look at it in the context with the other two? So,
Mr. Chair, I don't believe it was referred. I don't think you need to formally make a motion, but you want to just to make it official.
Also move, Mr. Chairman.
All right. Well, look at motion from Senator Surville to say we'll look at from Senator Spruill to say we'll look at Senator Surville's bill when we look at the other related bills on provider contracts. Is there any discussion on that? It's been a motion and a second. All right. All in favor say aye. Aye.
Aye.
All opposed no. All right. That passes. There's no opposition. So we will include Senator Surville's bill with the others related that are dealing with the provider contracts. All right. Anything else on the bills being referred from the 2021 session? All right. Then we're now down to the step one analysis of the legislation referred to the commission during the 2020 session. And who's going to present on that?
Good morning, Mr. Chairman. My name's Don Beatty. I'm with the Bureau of Insurance. Thank you for allowing me to make this presentation. I'm going to start with House Bill 39, Special Enrollment for Pregnant Women. House Bill 39 requires health carriers to allow pregnant individuals to enroll in a health benefit plan at any time after the commencement of the pregnancy, with the pregnant individual's coverage being effective as of the first month in which the individual receives certification of the pregnancy. Section 38.2-3448 of the Code of Virginia allows health carriers to restrict guaranteed issuance during open enrollment or special enrollment period for the individual or group markets. Special enrollments established by federal law under 45 CFR 155420 for individual and small group insurance purchased through the federal facilitated exchange may be provided at any time for certain triggering events such as marriage, birth, or adoption that are defined by federal law. The Virginia Exchange currently uses the federal facilitated exchange platform, and therefore Virginia cannot require additional or extended special enrollment periods. No benefit is provided, and therefore no determination of applicability of the essential health benefits is required for this assessment. We did conduct a survey of carriers through the Virginia Association of Health Plans, and they did respond indicating concern that enactment of the special enrollment periods increases the risk of individuals getting and dropping coverage and volatility of rate establishment processes. Next, I have House Bill 59, Assessment Licensing of Athletic Trainers. House Bill 59 requires health insurers and health service plan providers whose policies or contracts cover services that may be legally performed by a licensed athletic trainer to provide equal coverage for such services when rendered by a licensed athletic trainer. The bill adds athletic trainer to the listing of practitioners other than physicians that may receive reimbursement if an accident and sickness insurance policy or health plan provides coverage for their services. All qualified health plans are currently required to provide certain coverages as provided for in the Virginia Essential Health Benefit Benchmark Plan. However, the benchmark plan does not provide coverage for services provided by athletic trainers. No benefit is provided, and therefore no determination of the applicability of essential health benefits is required for this assessment. In our survey, none of the carriers commented on this bill. Next, I have House Bill 579, Step 1 Assessment Coverage for Mammograms. House Bill 579 provides for coverage of low-dose screening mammograms. Low-dose screening mammography refers to a mammogram with an average radiation exposure of less than 1 rad per breast for 2 views of each breast. Frequency of mammogram coverage required by the bill is based on family history of breast cancer and age, as shown in the table below, with a family history for age 35 to 39. If you have a family history of breast cancer, you get an annual exam. 40 to 49 also annually, age 50 twice annually. If you have no family history, age 35 to 39, one. During that time frame, age 40 to 48 biannually, and age 50 annually. The provisions in the table apply to plans delivered, issued for delivery, reissued, or extended on and after January 1, 2021. Plans from 1996 to January 1, 2021 are only required to provide mammograms to all covered individuals with the frequency indicated for no family history of breast cancer. The bill does define family history of breast cancer as one or more of the individual's first-degree blood relatives having had breast cancer. For step one analysis, Bureau analyzes the extent to which the proposed mandate is currently available under the qualified health plans in the Commonwealth. Under federal policy, benefits mandated by state action taking place after December 31, 2011 are considered in addition to the essential health benefit, even if the mandated benefits are also embedded in the state's selected benchmark plan. In such cases, states may be required to defray the associated costs of the qualified health plans. A survey of carriers by the Virginia Associative Health Plans indicates that carriers generally cover one or more mammograms for a person aged 35 to 39 and an annual mammogram after age 40. Non-indicated coverage for persons under the age of 35. As this is a new benefit mandate, it would be considered in addition to the EHBs. Next, I have House Bill 645, Step 1 Assessment, Broader Diabetes Coverage. House Bill 645 provides for coverage of insulin, certain equipment, certain supplies, regular food care and eye care exams, and up to 3 in-person outpatient self-management training and education visits upon an initial diagnosis of diabetes, and up to 2 such visits upon a significant change in an individual's condition. The bill provides greater specificity than the current law, requiring coverage for equipment, supplies, and consultation, and specifically allows consultation through telemedicine. The bill also provides that benefits or services required for the treatment of diabetes are exempt from any deductible. These provisions apply to any insurance policy, contract, or plan delivered, issued for delivery, reissued, or extended on and after January 1, 2021, or at any time thereafter when any term of the policy, contract, or plan is changed or the premium adjustment is made. Step 1 analysis, the Bureau analyzes the extent to which the proposed mandate is currently available under qualified health plans in the Commonwealth. Under federal policy, benefits mandated by state action taking place after December 31, 2011 are considered in addition to essential health benefits, even if the mandated benefits are also embedded in the Virginia benchmark plan. A survey of carriers performed by the Virginia Association of Health Plans indicates that carriers provide coverage currently with low copays. Some provide foot and eye care currently also. Some carriers recommend that diabetes should not be treated differently from other medical conditions. The state may be required to defray the associated costs of qualified health plan of such benefits. As House Bill 645 is a new benefit mandate for diabetes, it would be considered in addition to the EHBs. Next, I have House Bill 7776, Step 1 Assessment for Fertility Preservation Procedures for Cancer Patients. House Bill 776 requires coverage for standard fertility preservation procedures that are medically necessary to preserve the fertility of a covered individual due to the covered individuals receiving cancer treatment that may directly or indirectly cause infertility. All qualified health plans are currently required to provide certain coverages as provided in the Virginia Essential Health Benefit Benchmark Plan. However, the following family services are excluded from the benchmark plan: assisted reproductive technologies, and related diagnostic tests, and drugs including artificial insemination, in vitro fertilization, zygote intrafallopian transfer, or gamete intrafallopian transfer, or any other types of artificial or surgical means of conception. As such, infertility treatments are excluded from the EHBs. The Bureau would therefore characterize extending coverage for fertility preservation procedures for cancer patients, as outlined in HB 776, as a new mandate which may cause Virginia to defray the cost. The bill defines standard fertility preservation procedures to include sperm and alkaline cryopreservation. Survey results. A survey of carriers performed by the Virginia Association of Health Plans indicated that carriers responded to the survey do not provide this coverage in Virginia, although there is a level of coverage in Maryland. The Department of Human Resources Management has estimated the fiscal impact of House Bill 776 on the state health plan at $1.2 million, based on the 2.5% of cancer patients projected to utilize cryopreservation. Qualified health plans could expect similar costs. Next, I have House Bill 1076, Step 1 Assessment Coverage for Mental Health Screenings. House Bill 1036 requires a health carrier to provide coverage as a preventative service for at least 6 annual therapy or counseling outpatient screenings or visits with a licensed mental health professional for the early detection or prevention of mental health. Health carriers are prohibited from imposing cost-sharing requirements for mandated preventive services. Step 1 analysis. All qualified health plans are currently required to provide certain coverages as provided in the Virginia Essential Health Benefit Benchmark Plan. Mental health and substance use disorder services is an EHB category, and diagnosis and treatment of psychiatric conditions, coverage for office visits, outpatient facility physician charges, and medication check visits are covered. There's no specific coverage for mental health screenings used for early detection or prevention of mental illness. A survey of carriers performed by the Virginia Association of Health Plans indicates that mental health screenings are covered in accordance with federal guidelines on mental health parity. Some carriers cover these screenings with applicable cost-sharing requirements. Under federal policy, benefits mandated by state action taking place after December 31, 2011 are considered in addition to essential health benefits. In such cases, states may be required to defray the associated costs of qualified health plans for such benefits. As this is a new benefit mandate, it would be considered in addition to the EHB. Unless this meets federal preventative care requirements, the state may be required to defray costs. Next, I have House Bill 1384, Assessment Provider Contract Changes. House Bill 1384, I think that was Senator Sorvel's bill that he mentioned earlier, amends 38.2-340715, Ethics and Fairness in Carrier Business Practices, to provide that changes made in provider contracts are not to be effective unless agreed to by the provider in writing. This is not a coverage required by the Virginia Essential Health Benefit Benchmark Plan. No determination was made as to the applicability of the essential health benefits as necessary, since this is not a mandated benefit and is not really eligible for a Step 1 access. No carrier had comments on this bill. Next, I have Senate Bill 1982, Assessment Physical Therapist Office Visits, Cost Sharing Requirements. Senate Bill 192 prohibits plans which include coverage for physical therapy from imposing any cost sharing requirement, such as co-payment, co-insurance, or deductible for physical therapist office visits that exceeds the cost sharing requirement for a physician or osteopath office visit. The Bureau analyzed the extent to which the proposed mandate is currently available under qualified health plans in this Commonwealth. The provisions of this bill neither mandate a benefit nor a provider. This bill places limits on cost-sharing requirements for a physical therapy office visit in relation to a physician or osteopath office visit. Therefore, no determination of applicability of essential health benefits is required for step one assessments, and none of the carriers commented on this bill. And what I think is last, but is Senate Bill 1086, Step 1 Assessment Coverage for Infertility Treatment. Senate Bill 1086 requires plans to provide coverage for infertility treatment. All qualified health plans are currently required to provide certain coverages as provided for in the Virginia Essential Health Benefit Benchmark Plan. However, the following family planning services are excluded from the benchmark plan: assisted reproductive technology and related diagnostic tests and drugs, including artificial insemination, in vitro fertilization, zygote intrafallopian transfer, and gamete intrafallopian transfer, or any other types of artificial or surgical means of conception. The bill defines infertility treatments to include these services, which are specifically excluded from the HBs. Under federal policy, benefits mandated by state action taking place after December 31, 2011 are considered in addition to essential health benefit, and the Bureau characterized extended coverage for infertility treatment outlined as a new mandate that may cause Virginia to defray the cost. On the results of our survey, where the carriers generally do not offer infertility coverage, although they do coverage tests to determine the cause of infertility and treatments for any underlying medical conditions. And I believe, Mr. Chairman, that concludes my report. Oops. I've lost you, Mr. Chairman.
All right. Are there any questions or comments that anyone has related to the items discussed in this report?
Mr. Chairman?
Yes, Delegate Ware.
Yes. These that have just been reported by Mr. Beatty, what is the proper procedure going forward if we wanted to move these along or recommend on them?
But the next action, the action that would be potential for moving this further along would be to ask a step two assessment of one or more of these items. Those are more, take longer time to do and are costly to do. So we don't want to do that on everyone, but there clearly could be some that we could put in that category. What I would suggest is we will be hearing public testimony on a lot of these issues today, and that we take this, have staff send out the information that's been provided, and that we take a look at it prior to our next meeting and figure out sort of what we want to do in terms of taking action for a step two assessment at our next meeting.
Thank you, Mr. Chairman.
Certainly. All right. Is there anyone else who has observations or questions on these pieces of legislation that have been referred to us?
Mr. Chairman?
Yes, Senator Sorrell.
Could I just say that I think it would be helpful if we could get like a scorecard on all that? You know, like if we had a chart that showed here are the bills, here's a quick summary. Here's,
right.
You know, so we could see it all together on one piece of paper, and you know, instead of trying to keep it all together in our head, that was a lot of information to uptake at once. So it would just be nice to see that, I think.
Well, I think Mr. Beatty might be willing to give us all his phone number so we could harass him. But I think that's a good idea to try to be able to synthesize things and have something where we could sort of have a side by side and figure out which ones are the more is more important to get to a step two.
Mr. Chairman, I would be happy to give everybody my phone number. Several people have it, but in lieu of that, we might just provide the chart.
I appreciate that. So thank you. All right. Any other questions on any any of these items? All right. Well, we will be addressing some of these when we have our next meeting there and making decisions as to whether we move forward with step 2 assessments on any of these pieces of legislation that were filed during the 2020 session. And getting that information or other actions that might be taken at that time. And we will clearly be hearing some public comment on some of those things. There will be some other items that will be worked on, what we will also take up at our next meeting as well. Is there any further discussion or comments or questions from anyone on the HERT before we move to public comment? All right, thank you. Okay, we will now then move to public comment. I understand there's more than a couple of dozen people who signed up, so we're going to have a robust public comment period today. And I think what we'll do is limit it to 2 minutes per person so that we can hopefully get done within less than an hour on the public comment there.
Understood,
yes,
Mr. Chair. That being the case, for those of us in the queue waiting to hear, I believe that there are 29 of you presently. We are going to see who is at their computer and ready to comment and actually interested in commenting rather than just in watching the proceedings. So at this time, anyone interested in participating in public comment, please use the Zoom raise your hand feature. I'll get you down on the list and call you in order. After 2 minutes has expired, I will get on the mic and let you know that your time has been allotted. Beginning presently with Miss Kenzie Davidson, I am moving you into the room. And Miss Davidson, please go ahead.
Hi, my name is Kenzie Davidson. I'm a constituent from Arlington, Virginia. I am coming to you a day after I have learned again that I will not become a mother this month. We must pass Senate Bill 1086 without further delay. More than 25,000 families in Virginia, 1 in 8, have trouble conceiving or carrying a pregnancy to term, and we do not have time to wait another year for access to advanced reproductive technologies and fertility preservation. Having children is fundamental, and being unable to have a child has affected me physically, financially, and emotionally. In 2017, my former partner and I tried to have a baby for over a year. We were caught in a monthly cycle of trying, getting our hopes up, experiencing crushing disappointment, and then back to trying again, and eventually our relationship fell apart. In 2019, I went through 4 rounds of infertility treatments, including IVF. Over 6 months, I spent $35,000 out of pocket, again in 6 months, because health insurance providers are not required to cover the actual treatment of infertility. And I had to stop pursuing motherhood because I ran out of money. I have been on an embryo donation list, meaning I'm willing to receive an embryo that is no longer needed by a family who has successfully pursued IVF for 2 years. I have been trying to have a baby for almost 4 years. I have a new marriage, and I still don't know how I'm going to become a parent. These out-of-pocket expenses associated with fertility treatments are so high that paying for future IVF cycles would adversely impact my husband and my ability to provide for our baby if the treatments are successful. I am not the only Virginian to experience this heartbreak, and I ask you to please, without further delay, support the pro-family legislation on the table today. Thank you.
Thank you very much, Ms. Davidson. Ms. Deborah Steppel, you are next.
Okay, thank you. Hi, I am Deborah Stapel from Reston. I want to thank you all for the opportunity to speak to the committee today about studying insurance coverage for infertility this year instead of placing it on hold until 2022 so the legislature can act on it in the 2022 session. This issue matters to me personally. Many of you already know that my husband and I have 2 teenagers. What you might not know is that despite only having 2 children, I've actually been pregnant 8 times. I miscarried 4 times. I had 2 ectopic pregnancies, both before and between the pregnancies which became our kids. We are just one example of the 1 in 8 Virginia couples that were mentioned earlier who need medical intervention in order to build their families. While we were lucky to have had private insurance coverage for the medical care we needed to create our family, so many Virginia couples are not so privileged. Biological clocks continue to tick even through a pandemic. Cancer patients who need to preserve their fertility in order to create their families after their cancer treatments need insurance coverage now. Delaying the study of insurance coverage for couples who need treatment in order to conceive will most certainly prevent some Virginia couples from ever being able to create their families at all. These Virginians need insurance coverage for the medical treatments that will help make our Commonwealth stronger by allowing them access to what they need to create their families. Can we count on your support to begin studying insurance coverage for infertility and fertility preservation this year with no delay by accepting the recommendation of the Rules Committee on HJ 545 to advance this bill in 2021 so the legislature can act on it in the 2022 session? Thank you for your time this morning.
Mr. Gray, Mr. Doug Gray, you are next. Doug,
good morning, members of the Health Insurance Reform Commission. I'm Doug Gray on behalf of the Virginia Association of Health Plans. I just wanted to make a policy comment. One challenge that we have going forward as we continue to address the many mandates that are in front of the committee is that there are real policy issues represented by each of the proposals. So if you have a proposal that mandates a new benefit that goes beyond the essential health benefit, that's that whole issue of whether it creates a cost that needs to be paid to the federal government or a cost for the state health plan or elsewhere. But there are other proposals that seek to, for example, add an essential health benefit requirement that would be covered with no cost at all. That conflicts with federal policy on an essential health benefit. So could we change to a new essential health benefit? There might be a process to do that. There needs to be a discussion about that at some point. So my point is that there are real policy issues that need to be discussed outside of the context of the many individual requests that really do apply to many of them. So we could either categorize them in groups or we can talk about the policy issues as a separate topic. But every issue that comes to the HERC is not a mandated benefit. And many of them are really a bigger policy issue. And so I just think that's something we should keep in mind as we design our discussions going forward. I mean, obviously, we have to address each of the things that have been brought, but we also need to understand and address the underlying topics. And there are at least 3 large policy areas that need further discussion and understanding amongst the HERC members, amongst all regulators, and amongst all legislators and the public. And so I just wanted to make that comment as a conceptual item that needs to be discussed as we go forward. Thanks.
Ms. Cholera, Barbara Cholera, you are next.
Hi, everyone. My name is Barb Cholera, and I live in Herndon, Virginia. And I am also the president and CEO of a nonprofit organization called Resolve, the National Infertility Association. Resolve has been around for nearly 50 years. We're a patient advocacy organization based in McLean, Virginia. We provide support and resources across the country to people who are struggling to build their family. As a Virginian, I'm very excited that we get the opportunity as a constituent to share that I too want to see HB 776 and SB 1086 advance to your step 2 assessment. We would very much like the legislature to take these issues up in the 2022 session. I will tell you that as a patient advocacy organization, we are the organization fighting for this same sort of insurance coverage in other states. We have been very successful in passing legislation, most recently in New York State and in Colorado, also in New Hampshire and Delaware, and several other states just in the last couple of years. We're very happy to provide that expertise, those cost studies that were done in those states to Virginia and any other resources that we can provide. I want to note that the state of Maryland does have this coverage for both fertility preservation and IVF and have had it in place for over 25 years. That's obviously a neighboring state and has provided so many people the chance at parenthood. I also want to just leave you with the fact that Virginia has a very important distinction. It's the home of the first IVF baby ever born in the United States in 1981, right here in Virginia at Norfolk. So wouldn't it be amazing to see our state take on this pro-family legislation that really Virginia shepherded so many years ago? Again, Resolve is here to serve you and help you. And I, as a Virginian, lend my help and expertise in any way possible. Thank you.
Miss Betsy Campbell, you're welcome to unmute yourself and go ahead. Miss Campbell, are you still with us?
Yes, I am. Thank you. Just needed to unmute. I'm Betsy Campbell. I live in McLean, Virginia. I also have the honor of working for Resolve, the National Infertility Association, as Chief Engagement Officer, headquartered here in McLean. Resolve has worked in many states to pass similar pro-family legislation as 776 and 1086. So as Barb said, we have significant experience working with states to pass new insurance mandates and doing so in a way that does not run afoul of the Affordable Care Act. Regarding the Affordable Care Act and essential health benefits, the determination of when a new coverage mandate would trigger a defrayal requirement is entirely up to each state. And publicly available information suggests that no state has been required to make defrayal payments on new mandates passed since 2011. Maternity care and rehabilitative and habilitative services are already considered essential health benefits, and infertility treatment falls within these categories. It is
Ms. Campbell, I believe that you're muted.
all right. Can you hear me now?
Sorry, apologies.
Okay. Did you hear that maternity care and rehabilitative services are already considered essential health benefits, and infertility treatment falls within these categories? It's important to note that 3 states have passed new IVF laws since 2018, and several more states have amended their infertility insurance laws to make them more comprehensive and expand to new populations. And 11 states have passed new fertility preservation laws since 2007, and none have been required to defray the cost. I'd also like to add that language can also be added to these bills that if HHS rules that a defrayal is required, which is unlikely, but if it does, then that section of the bill can be voided to protect the state against any potential costs. And we're happy to share this language and our experience in other states with everyone here today. Thank you.
Thank you very much, Ms. Campbell. Mr. Michael Puglia, please unmute yourself and go ahead. Thomas Bohannon, you will be next.
Mr. Chair, members of the commission, thank you for considering HB 59. today. My name is Michael Puglia. I am a constituent here in Richmond, Virginia. I am a licensed healthcare professional, licensed and certified athletic trainer, practicing healthcare here in the Commonwealth of Virginia. We're asking that you support HB 59, that we have HB 59 reach a step 2 assessment, and hopes of having that come to the legislative session in this next legislative session in 2022. I wanted to just make clear that as a licensed healthcare professional here in the state, or that athletic trainers are licensed healthcare professionals here in the state of Virginia, we practice under our scope. We are individuals who work under the direction of physicians, and we have had at the present time struggling to receive reimbursement from third-party payers for legally licensed healthcare services that we deliver to our patients here in the Commonwealth. We are individuals who have national provider identification numbers and taxonomy code, and have our own taxonomy codes. We provide injury prevention, evaluation, rehabilitation, and emergency management to athletes and those who are physically active here in the Commonwealth. We currently can be found in our current procedural terminology codes. We have our own CPT codes that we are allowed to bill for. And the issue always comes back to whether we're billing. It's not whether we are billing, it's whether we are able to get reimbursement for these services from third-party payers. It has been a barrier. This has been a barrier for a long time for our profession, and it is something that we would like to see changed. We feel like we have done a great deal of work here on our own to position ourselves, whether it's having licensure, having the education, having master's level education. Myself, I got my education here in the Commonwealth from James Madison University, and a proud alumni there, and that we're able to then use our MPI numbers and our CPT codes. We believe that we should be able to render these services and be reimbursed for these services. So we'd like to see, I guess this is the next step for us, and we'd like to see get the support from the commission to move forward as we try to have equity as it comes to our third party reimbursement. And so we ask you guys we ask you for your support of HB 59, ask that this goes to a step 2, and hopes to have this presented in the next legislative session. Thank you.
Thank you, Mr. Puglia. Mr. Bohannon, you're welcome to unmute yourself and go ahead. Lee Newsbaum will be after you.
Hi, I'm Tom Bohannon, a physical therapist here in Richmond, Virginia, and I'm asking, and a representative for the Virginia Physical Therapy Association, and I'm asking you to support Senate Bill 192. It will decrease copays to the same level as primary physician copays. It will also prevent managed care companies from requiring patients to pay excessively high copays for physical therapy treatment. Often patients are asked to pay high specialty copays for physical therapy services, and they can't afford it, sometimes $50 or $75 per visit. This is often as much as the insurance pays for that specific visit. So the patient is 100% responsible in a lot of cases, despite having insurance for coverage for that visit. It limits the frequency, and it often leads patients to using more opioids, having more special tests, more expensive surgeries, and more issues related to recovery. And oftentimes they don't get back to work or doing the activities they need to do because they forego physical therapy services. The practice of PT is different in that it requires multiple visits. It's not a single visit once a month, once a year. It's typically 3 to 4 visits, 4 to 5 visits, sometimes over several weeks. Sometimes it could be twice a week for a month or more, depending upon the patient's injury. And that can add up as patients go along paying higher copays of $50, $75, or sometimes $100 per visit. They just create a disincentive, and it can rise as high as $600 per month for patients. So we ask that you support this bill and help reduce costs for patients. It also will help reduce costs for insurance companies, as there are multiple studies that show that there's a significant up to a 27% downstream reduction in cost if they reduce copays. United Healthcare and TRICARE both now have plans that reduce copays down to nothing for the first few visits for low back pain, and it's been working quite well. So we ask that you support 192, move it to the next stage, and help us get reduce healthcare costs for patients in Virginia. Thank you.
Thank you, Mr. Bohannon. Lee, you're welcome to go ahead. Tiffany Jefferson will be after you.
Great. Thank you so much. Good morning, Mr. Chairman and members of HERC. It's been a while since I've seen all of you, but I really appreciate the opportunity to speak. My name is Lee Nussbaum, and in addition to having the honor of working for our Speaker of the House from 2015 to 2019, including serving as her Chief of Staff when she was Minority Leader, actually, as I was thinking about it, I've spent a lot of time prepping her and sat in on a number of these HERC meetings myself for about 4 years, and I've worked with a number of you on multiple pieces of legislation. I'm also a constituent of Senator Spruill, and perhaps the reason why I'm here is I'm also Jones Institute IVF baby number 588. I come here today simply as a Virginian who would not exist without the miracle of in vitro fertilization. And as several people have already mentioned, this was pioneered in my hometown of Norfolk at the Jones Institute for Reproductive Medicine. And that's actually a picture of me with Dr. Georgiana Jones, one half of the husband and wife team that pioneered this treatment. She's quite literally one of the doctors directly responsible for my existence. Now I've just switched the background behind me for a reason as well. It shows my mother, father, and while my head's blocking it, 1-year-old me meeting with then Governor Doug Wilder to lobby in support of insurance coverage of IVF and other artificial fertilization means. Now, to give you a perspective of how long this has been going on, Delegate Jay Jones's father introduced a bill in 1990 to that effect, and it went to HERC's forerunner, the Commission on Mandated Health Insurance Benefits. And though a bill never made it out of the General Assembly at that time, as we've seen, a lot's changed since then. As of April 2021, 19 states have passed fertility insurance coverage laws. 13 of those include IVF, and 11 states have fertility preservation laws for iatrogenic, medically induced infertility. And for the record, it's a mix of red and blue states. For Delegate Ware, I just want to stress we'd be no different from Arkansas or Utah by moving forward here. And it's my hope that we can take another look at this through HERC and eventually set Virginia, the birthplace of in vitro fertilization in the United States, up to be the 20th state. Thank you so much for your time.
Thank you very much, Ms. Nussbaum. Tiffany Jefferson, you're welcome to go ahead. Bryce Snyder will be after you.
Good morning, everyone. Thank you so much for this opportunity. My name is Tiffany Jefferson, and I am a constituent of the city of Richmond, Virginia. And I am here to advocate on behalf of HB 776 as well as 1086. I was actually born on January 6th of 1986, and I think there is some connection. I am 35 years old, and my husband proposed to me on March 24th of 2020. We could not wait, so we got married on August 1st of 2020. It's been 11 months, and we have been trying to start our family, and we cannot. Do you know why? No, it's not because of my age. It's not because I'm 35. I married my husband, who was 27 years old at the time, and he was diagnosed with low testosterone, which causes him to have a low sperm count, low fertility, which is preventing us from starting the family. We were told by our doctors that the only way to treat this issue was with infertility treatment with IVF. So I am asking and begging and pleading that you give my husband and I this opportunity to start the family that we have always wanted. My husband is a pastor and a Virginia music education teacher for Chesterfield County Public Schools. And I am a family services worker with the Department of Social Services here in the great state of Virginia. We would make excellent parents, and we want our dreams to come true. This cannot wait. Every year that we wait, my egg reserve and my egg quality goes down. At 35 years old, I cannot keep waiting until I'm 36 and 37 and 38 when things just get worse. We cannot wait. Let's make this change now. It's been 31 years. We can't wait another year. Thank you so much for your consideration. I appreciate it.
Thank you very much, Ms. Jefferson. Before I let you go ahead, Mr. Snyder, I'd like to announce that at present, I have no one else who has used the Zoom raise your hand feature and is in the queue to speak. If you would like the opportunity to submit a public comment, but have not yet done so, please do use the Zoom raise your hand feature at this time. Mr. Snyder, go on ahead. Thank you.
Yes, hi, good morning, everybody. Bryce Snyder from Virginia Beach, Virginia. Just following up on what Mike Puglia spoke about earlier about HB 59 for athletic trainers and adding them to some of the insurance codes of Virginia. As we heard from the Bureau of Insurance, they determined that there's no determination no impact on essential benefits in seeking the addition of athletic training. So we hope to expedite this bill being passed and being referred back to the House of Commerce and Labor in the next session, and not really needing a step 2 analysis. And just to provide some further information, again, athletic trainers are licensed healthcare professionals in the Commonwealth of Virginia. The vast majority are master's level educated, and we're board certified by a national board of accreditation. And we have NPI numbers, or national provider identifier numbers, and also a specific taxonomy code. We also have current procedural terminology evaluation codes, and we utilize the physical medicine and rehabilitation codes within the CPT book. At present time, we're struggling to receive reimbursement for third-party payers. This has been long-standing for several years. And just to give you an example, we completed a self-survey of our own association, and our consultant contacted multiple third-party insurance companies. And an example we got back from an insurance plan was that athletic training is considered not medically necessary for enhancing athletic performance or for recreation. And that clearly shows the struggle we have when we discuss who athletic trainers are and what we do. And again, I go back to the whole, we're licensed medical professionals. We have a code of athletic training, which outlines what we're allowed to do and not to do. So again, I support this bill, and thank you to Delegate Lee Ware as well for patroning this bill for us. And we hope to move this forward without even needing a step 2 analysis. So thank you for your time, everybody. Have a good day.
Thank you, Mr. Snyder. Mr. Chair, at this time, that concludes everyone in the webinar who has indicated a desire to participate in public comment.
All right. Thank you very much to all the people who testified today. And we'll take those comments and relate them to some of the bills that have been presented today and that we will discuss at our next meeting. At this point, is there any further business that we have, or anyone wish to make any comments or questions? All right. If not, is there a motion? We will meet probably after the special session, latter part of August would be my guess for the next meeting. And we'll work on getting an acceptable date for everybody then. And we'll do a email, send out an email to get information on when people are available, and also then to provide the information that's been shared with us today. If there's nothing, no other business anyone has, is there a motion to adjourn?
So moved.
All right, we got a motion and a second to adjourn. All in favor say aye.
Aye.
Aye. All opposed, no. Thank you all for participating. So.